Very good afternoon to one and all. Today topics for discussion is tourniquet. As you all know the routine use of tourniquet, now I am going to discuss about the anesthetic implication of tourniquet. So moving on to the history, that is the person who has found out the tourniquet was James Louis Peter, who coined the word tourniquet from the French word tourner in the year 1718 when he used this for lower limb amputation surgery. Then there are few types of tourniquet based on their function, pneumatic one and automatic one. Mostly we are using the pneumatic one. Pneumatic one has three basic principle. It has a cuff and a compressed gas and a pressure gauge. So with the cuff we have to tie it in our limb, then wrap around the three-fourth of the limb. Then with the source of compressed gas, we have to inflate and with the help of pressure gauge design so that we have to maintain the pressure to compress the artery. Then automatic tourniquet is also used nowadays where we have to preset the pressure what we are going to inflate. Here we have to manually inflate, whereas in automated we have to just reset before inflating how much pressure we are going to give for compression. Then moving on to the uses. So by applying the tourniquet pressure, we can obtain a bloodless surgical field. So with the bloodless field, which is mainly useful for the better visualization of the structures, what we are going to operate and to reduce the operative time. If it is messed with blood, so the operating time is prolonged. So by using the tourniquet, we can reduce the operating time and we can reduce the surgical complications because with the help of clean surgical field, bloodless field, we can see the surgical plane very clearly so that we can reduce the surgical complication and we can reduce the need of blood transfusion also. So by avoiding this unnecessary blood loss, we can reduce the transfusion need. So uh, overall, the tourniquet uses to decrease the bloodless, that is bloodless field in the surgical place. So once again, I am repeating for bloodless surgical field for better identification of structures and to reduce the operating time, to reduce the surgical complication, and also the most important is to reduce the blood transfusion. And also the tourniquet is used in intravenous regional anesthesia where the local anesthetics is injected through the vein so that the desired action is obtained in that particular area. And few other for limb isolation, that is for amputation surgeries or any localized malignancy, we can use this tourniquet to reduce the bloodless field, to reduce the blood loss. So moving on to the anesthetic responsibility. The anesthetic responsibility is main thing is we have an adequate preoperative assessment. So proper assessment is needed for selecting the patient. They should not have any peripheral vascular disease. If they are having any peripheral vascular disease by injecting the by inflating the cuff, we are manually making the patient still more complicating the blood supply to the affected limb. So proper history taking is more important. So adequate preoperative assessment is needed. And we should use the adequate size, that is proper size, and it should be fit to the patient. It should not, the cuff should not be too loose or too tight. If it is too loose, the desired compression is lost. If it is too tight, it will too much compress the blood supply and also compromise the uh, nerve injury also. And we should have an accurate and effective pressure should be given to the limb so that we can get a clear field, that is clear bloodless field for easy operating to the area. Then we should have the proper pressure, that is cuff pressure, that is systolic. We are having some desired systolic pressure based on the upper limb or lower limb. That slide I am dealing it in subsequent slides. And we should inform the surgeons when the tourniquet is applied and what is the desired time we are going to stop, and what is the time left out. These are all the most important thing that the anesthetist should be keep an eye before starting the any procedure. So the most important anesthetic responsibility is to have an adequate pre-anesthetic assessment. So for finding any peripheral vascular disease and proper size and proper fit of the cuff should be maintained, and adequate and effective pressure should be given to the limb, and the systolic pressure and the cuff pressure we have to check before using it, and we should inform the surgeon regarding the tourniquet time, when it has been started, when we are going to finish. So these are all the anesthetic responsibility. And moving on to the pressure. What is the desired pressure kept for the lower limb or the upper limb surgery? So we should maintain the normal systolic blood pressure. It is our 120. That is 120/80 is the normal blood pressure of it in the systolic blood pressure. For example, if a normal person is having 120, we have to add 150 extra, 150 millimeter of mercury for intravenous regional anesthesia. Whereas for all lower limb surgeries, if you want to operate for the tibia surgery or any distal KOL for tarsal, metatarsal KOL, so we can use in the lower limbs. So in that case, for lower limb, we have to add 100 millimeter of mercury to the normal systolic blood pressure. Whereas for the upper limb, we have to add plus 50 millimeter of mercury for upper limb surgery. We should give more pressure uh, by adding the systolic blood pressure. 100 is for lower limb and 50 for the upper limb. Then moving on to the most important thing is the tourniquet time. So after tying the tourniquet, we have kept the pressure, and now we are going to see the tourniquet time, how long we are going to keep the time of inflation. So the minimum time for intravenous regional anesthesia is 30 minutes. And it is ideally for upper limb and lower limb surgeries, it should be 40 to 60 minutes. And the maximum duration of inflation is 2 hours. If it is more than 2 hours, then we have to deflate for 5 minutes. In between, we have to, if it has crossed more than 2 hours, then for every 5 minutes, we can release the pressure. Intermittently, we have to reperfuse that area by releasing the pressure. And as you all, the maximum time of inflation is 2 hours. And if it is crossing, the surgery is crossing for more than 2 hours, then we have to deflate it for every 5 minutes for intermittent perfusion. Then the ideal time for upper limb and lower limb surgeries, the tourniquet time is not more than 1 hour, that is 45 to 60 minutes. Then the specification of tourniquet width. One more thing is width. We have to adequate with this cover is more important. If you are using very small size cuff or very bigger size cuff, whatever desired pressure we are going to give for compressing the artery won't be adequate for getting a bloodless field. So the width of the cuff plays an important role. So it should be 8.5 centimeter, the standard width. So width of the inflated cuff to be more than half of the limb diameter. So we have seen the how much pressure we are going to keep and what is the width of the cuff we are going to we have seen, and now the ischemic time also we have seen. The ischemic time we have to inflate the time for not more than 1 hour, and the maximum time is 2 hours we have kept. If it is crossing after 2 hours, every 5 minutes intermittently we have to release the pressure. So now how we have to give the caution to the surgeons, that is ischemic time information to the surgeons. For the first 2 hours, we have to inform the surgeon every half an hour. So now it is half an hour crossed. Then it is 1 hour crossed, 1.5 hours. So like that, every half an hour, we have to inform the surgeons for the first 2 hours. And for the next 2.5 hours, we have to intimate every 15 minutes. Now it is 15 minutes over, the second 15 minutes. So like that, we can cross for 2.5 hours. In between, we have to release the pressure for every 5 minutes. Intermittently, we have to release the pressure if it is crossing for more than 2 hours. So you have cleared, no? So we have dealt the pressure. Then Then how much pressure, what is the duration, and what is the width, and how and when the surgeon has to be intimated regarding the time. Then moving on to the contraindication. So the main contraindication for the tourniquet is, as I told, only this peripheral vascular disease, Raynaud disease, and deep vein thrombosis. Already the patient has undergone any AV fistula on that limb, we should not use the tourniquet. If the patient is having peripheral neuropathy, then the neuropathy symptoms will get aggravated. And severely injured limb, severe infection in the limb where the edema is visualized, so that whatever the limb pressure we are giving, it will further deteriorate the local infection. And any bone abscess, because bone we can't inflate anything, no, so only the thing is superficial surgeries we can use, so that if bone abscess is there, we can't use it. So once again, I am repeating the contraindication. If the patient is having any peripheral vascular disease, deep vein thrombosis, AV fistula, peripheral neuropathy, severe injured limb, or severe infection to the any of the limb, and bone abscess. So these are all the contraindication. And moving on to the changes, what we are going to see on cuff deflation. So there will be mild systemic metabolic acidosis and increased PaCO2, that is partial pressure of carbon dioxide, increased lactate level, increased potassium level, transient rise in EtCO2, that is end tidal carbon dioxide, transient fall in systolic blood pressure, transient fall in heart rate, and transient fall in temperature. This I will be telling you in later slides. Then moving on to the complications. As you all know, if the tourniquet is applied for the longer duration, they will have the nerve injury, tourniquet pain, post-tourniquet syndrome, compartment pressure syndrome, intraoperative bleeding, pressure sore and chemical burns, digital necrosis, toxic reaction, and thrombosis. These are all the complications we are likely to get. So I have told what are all the contraindication and what are all the complication. So once you have applied the tourniquet, the following are the physiological changes. What pathophysiology we are going to see? I have told us local wise and systemic wise. So the most important thing is nerve injury. That is the localized thing. So in that nerve injury, that is tourniquet palsy. Other name is, by applying tourniquet, the nerve get injured and getting paralyzed. So in most commonly involved is, if you are using in the upper limb, radial nerve, in lower limb, peroneal and tibial nerve palsy are more common. This is transient only, because we are transiently stopping the blood supply, and again the blood perfusion, that is we are reperfusing it by releasing the pressure in the cuff. So it is transient to reverse the loss of function, and it is irreversible if tourniquet paralysis syndrome occurs. So all the arterial tourniquets, that is including the newer automated device, can also be associated with the complications ranging from minor and self-limiting to the debilitated and even fatal. The systemic effects are usually related to main inflation and deflation of the tourniquet. The local effects and complication may be results from either direct pressure to the underlying tissue or ischemia to the tissue distal to the tourniquet. So here comes the nerve injury. The most common complication of tourniquet is paresthesia to palsy. So before applying the pressure, we will be applying the Edgemar's band to increase the cause of injury, and this may explains the fact that more susceptible to the mechanical pressure. And moving on to the most important cause, that is excessive pressure or insufficient pressure to the limb, leading to the mechanical stress, and finally in turn leads to ischemia or anoxia. So that if blood supply is lost, then invariably the oxygen supply to that area is also lost, and finally leading to tissue necrosis, damage. It may be slow or cessation of sensory and motor conduction also. So moving on to the preventive measures, how we can prevent this nerve palsy. The tourniquet which are used once the recommended time. As I told, it is not more than 2 hours. We should be very much certain about the time. And do not use faulty pressure gauge. So proper pressure gauge is more important. If we are keeping it a longer pressure and the pressure gauge is not working, then automatically complication is most likely expected. And the effective pressure to achieve the limb occlusion pressure should be obtained. And the use of cuff that properly fit the extremities. Apply the cuff at a proper location on the limb. Do not apply over the peroneal nerve or the ulnar nerve or the radial nerve. Avoid the tourniquet to slip or twist the limb manipulation. Do not pinch or kink the connecting tube. Then moving on to the muscle injury. Muscle injury is mainly caused by the ischemia that is beneath and distal to the cuff. So the extent of damage is related to the mainly the duration of the ischemia. So as the time increases, the intracellular concentration of creatine phosphate, glycagon, ATP, and oxygen is also decreased. Thereby, once the creatine phosphate is depleted by 2 hours, then ATP supply is also exhausted for 3 hours. Then lactate and potassium concentration, everything keeps on increasing. Once the pH is increases, intracellular pH decreases, that is the pH of 6 is reached by 4 hours, then the limb automatically will get fatigue and the muscle will get palsy. So if further the ischemia is prolonged, then irreversible muscle damage will get occurs. So the ideal time to prevent muscle injury is 2 hours because of the accumulation of intracellular creatine phosphate, glycosan, ATP, and decrease in oxygen level, and leading to the pH is also decreases. That is, pH is less than 6, then intracellular damage will get occurs. Then it will be leads to irreversible permanent damage to the muscle. Then moving on to the tourniquet pain. The tourniquet pain usually occurs 30 to 60 minutes after the regional anesthesia. If the patient is awake, then likely the patient will complain that they will feel mild pain, that is compression over the uh, uh, pressure where we have given in that area, they will feel the pain because due to the fast recovery of the unmyelinated C fibers when compared to the A fibers. Usually the pain varies from the anesthesia techniques where we have used, because in case of total intravenous regional anesthesia where it is more when compared to epidural, as is more when compared to spinal, but still more in case of GA. So if the patient is awake, then the patient will likely to get the pain, feel the pain due to the fast recovery of the unmyelinated C fibers. Then the use of hyperbaric tetracaine is more, they will feel the tourniquet pain when compared to the isobaric bupivacaine. The most important clinical features which is noted in the tourniquet pain is it is dull, deep, and burning and poorly localized pain. And patient will have sudden tachycardia, hypertension, and diaphoresis is also noted. Then moving on to the treatment of tourniquet pain is we have to immediately deflate the cuff. We have to sedate the patient by giving intravenous opioids or benzodiazepine. And for the localized pain, MLOC cream can be applied under the cuff, and double cuff application is also being used. Once the proximal cuff is inflated, then the distal cuff we can deflate. So like that, alternatively, we can use the double cuff application. Then moving on to the post-tourniquet syndrome, that is post-ischemic reactive hyperemia, and to restore the normal acid-base balance in the tissue for prolonged bleeding of the surgical wound. And here they will have edema, stiffness, pallor, weakness, and paralysis. These are all the things we will be known. we will be noticing. Moving on to the causes of post-tourniquet syndrome. As I told, whenever the ischemia time is prolonged, whenever the cuff pressure is prolonged for more than 2 hours, we will get automatically the supply is lost, then ischemia and neuromuscular injury. Then under pressurized cough. And the patient, if they are elderly and rheumatoid arthritis with the use of steroids and in case of calcified vessels. This can be prevented. That is, post-tourniquet syndrome can be prevented with proper adequate pre-op history and assessment. And history of any steroid intake or aspirin or vesicles, they are also more prone to get the post-tourniquet syndrome. So we can avoid this kind of peoples. And history of hypertension, coagulation profile, abnormalities, history of thromboembolic occurrence, evidence of arterial calcification, um, and there is any stitch with the recommendation tourniquet time limitation strict in the if they wanted to prolong, then simultaneously they are going to see the complication of the prolonged tourniquet time. So we have to stick on to the time and use of arterial occlusion pressures when the systolic blood pressure than the systolic pressure. Then moving on to the compartment syndrome. This is also one of the uh, major complication once if the tourniquet time is exceeded. This is a relative complication of the tourniquet. It can be either due to the external or internal pressure leading to the pain. And here they will have the tense skin, swelling, weakness, and paresthesia is noted. Usually the pulse will be absent in that case. And it is an irreversible palsy. So if it is tourniquets pain, we can reverse it. But whereas in compartment syndrome, it leads to permanent irreversible damage. That is permanent palsy. Um, the causes are, and it is a mostly unpreventable cause only. As I told, we should be stick on to our time. So trauma or surgery, whenever there is prolonged time more than 2 hours, and the pH is very low already, uh, we have kept as target as it's normal pH. If it is pH less than 6.4, then patient will likely to go for compartment syndrome. When with the increased capillary permeability and prolongation of clotting time, proper preoperative evaluation is more important, and the time should be less than 90 minutes to prevent the compartment syndrome. Then moving on to the intraoperative bleeding, where you will be seeing the most important causes where the pressure is not given properly. If you are not occluding the limb artery, so that the distal area will get perfused, and maximum we will be expected to get the bleeding in the operating field. So for preventing that only, we are using the tourniquet. Once the tourniquet is not fit to the patient or if the pressure is not given adequate, then we will have this intraoperative bleeding as a major complication. So under pressurized cuff, insufficient exhumation, exsanguination, um, avoid to slow inflation and deflation, and improper selection of the cuff, and excessive padding so that proper pressure is not delivered to the limb. A cuff that is applied too loose, where the supply given to that limb is not compromised. Then this can be prevented by following measures. We have to select the proper size, the tourniquet, and proper fitting, that is the proper style and size of the tourniquet cuff, and good examination because that is milking of the limb so that the blood which is distal to the surgery, distal to the cuff is uh, mobilized to the central compartment. That is good examination, and sometimes that is re-examination is also needed and considering for re-inflation after a higher pressure. Then moving on to the toxic reaction. This happens mostly in the case of total intravenous regional anesthesia, where deflation and underinflation or faulty or sudden release of the pressure of the cuff leading to the local anesthesia toxicity, where the local anesthesia is injected large in that particular area so that we can operate in that area. That is total intravenous regional anesthesia. It is bias block. This here double cuff is used once the cuff pressure is not given adequately. Large amount of local anesthetics is injected into the systemic circulation and leading to the immediate CNS and CVS effect. Patient will go for seizure and arrest. So to prevent that, adequate testing of the tourniquet is more important, and we should look for any allergic history, CVS and CNS or any vascular problem. We should have a proper history taking, and double bladder cuff is also more important, and limb occlusion pressure should be maintained. And intermittent deflation and reinflation of the cuff is also uh, fine. We should check properly and observe the patient physiological status. And moving on to the pressure sore and chemical burns. This is also expected in case of extremes of age group. Usually less with the pneumatic pressure cuff what we are using, whereas in automated cuff, pressure sore is more common. And when the pressure is increased, or when the time is increased, or when both pressure and time both are increased. Then, in case of sensitive skins, in the case of children, and discomfortable to the few patients, chemical and fluid accumulations under the uh, cuff is also likely to lead to pressure sore or chemical burns in the affected, that is, occluded area. Moving on to the causes and prevention. Inadequate padding can also is the most important cause. So we have to properly pad the patient before applying the cuff. Avoid too loose or too thin or flabby skin for patient to undergo this limb separation. So that if it is too loose or too thin or too flabby skin, we can't give the proper pressure to occlude the blood vessels. And if the skin is breakdown or friction or any soft tissue folding, we should avoid that. Leaks under the cuff or positioning of the cuff is also plays an important role. And correct limb protection technique should be followed. Do not readjust by rotation or damaging the tissue. And moving on to the digital necrosis. Prolonged constrictive or excessive or uncontrolled pressure leads to digital necrosis. This leads to mainly ischemia, anoxia, that is, oxygen supply is also reduced, finally leading to gangrene of the digits. This can be avoided by proper drainage or rubbing or glove bandage. Then moving on to the thrombosis, deep vein thrombosis and pulmonary embolism and lower extremity surgeries. So we should be very cautious to avoid the thrombus. Pulmonary embolism, where the tourniquet related leads to tourniquet related cardiac arrest. This can be prevented. Dislodgement now subtherapeutic use of heparinization, and avoid the elastic bandage for exhumation. This will cause proper too much tight to the limb and leading to the further spread of the uh, embolic to the heart or to the brain. So more, there are few other problems is also noted, like tourniquet pain, thermal damage. Whenever the pressure is that is pressure is given to that limb where the blood supply is stopped, then there will be a local rise in temperature. When compared to the central area, the area which is occluded, there the pressure where the temperature to the tissue is more and leading to the tissue damage by thermal injury and hyperthermia, rhabdomyolysis, and metabolic changes. These are all the few complications likely to be expected. So, before conclusion, as you all know, as a small summary of the complications um, related to our tourniquet is most important is nerve injury and tourniquet pain, post tourniquet syndrome, compartment pressure syndrome and intraoperative bleeding, pressure sores and chemical burns, digital necrosis, toxic reaction, thrombosis. So these are all the complication where this complication can be prevented if we are stick on to the time. That is the time of inflation till the time of deflation. So it should be not more than 2 hours. If it is more than 2 hours, intermittent every 5 minutes, we have to release the pressure so that we can reperfuse that area. So proper selection of the cuff and proper pressure and duration, we can reduce the complications. Okay, thank you. ஒரு பேரா சேர்ந்து வந்துட்டு ரொம்ப நம்ம